Hyperbilirubinemia, or Jaundice, by Jakar Brady, Ethan Colquhoun, Haley Matthews, and Jade Mansour. Today we will be discussing the topic of hyperbilirubinemia, the excess of bilirubin, a byproduct of red blood cells that when the liver is undeveloped does not excrete properly, causing issues for the baby, including jaundice. We will discuss our patient Henry, a premature baby that has been diagnosed with hyperbilirubinemia, complications that can occur, such as brain damage, because the bilirubin is toxic to the brain and increased amounts in the blood can cross the blood-brain barrier and accumulate, causing damage. We will discuss goals to help improve Henry's condition to prevent these complications and the nursing interventions to action these goals. They are focused on his temperature, therapy to reduce his jaundice and bilirubin levels, and ensuring adequate hydration. First, let's meet Henry. Henry is our patient today. Henry is 4 days post-birth and he was born at 34 weeks preterm and weighs 2.3 kilos. He's half Chinese and half Australian, and he was diagnosed with hyperbilirubinemia at 72 hours old, which is causing his jaundice. Mom, Jane, and Dad, Mark, have been married for 6 years. Jane is a kinder school teacher and has loved kids for as long as she can remember. Mark is a construction worker who works for his family business and works long hours. Jane is an Australian citizen and moved here when she was 3 years old with her parents from China, and Mark is a Caucasian Australian with a long line of Australian ancestors. Jane's sister had hyperbilirubinemia as a newborn and was at the special care nursery for 4 days. She has not had any complications since then. Henry was conceived naturally, and Jane and Mark are in both good health with no chronic illnesses. They have both been fully vaccinated. They had no issues with conceiving, and they also have a 4-year-old son, Jacob, who was also naturally conceived and delivered. Jade experienced no pregnancy issues other than gestational diabetes, which was well controlled for the entire pregnancy, and they had no other health concerns for his birth. Henry began breastfeeding at 3 hours post-birth with some issues due to lack of production of milk, as Henry is a preemie. Jane has suffered from gestational diabetes during this pregnancy as well, which increases the risk of jaundice, as gestational diabetes increases the chance of a preterm birth, which is ultimately a contributing factor to the excess bilirubin in the baby, causing jaundice. The signs and symptoms that most babies will have during jaundice is the yellowing of the whites in the eyes, which is one of the first signs, the head and the face, and in more serious cases, the rest of the body, and in very serious cases, the soles of the feet. The babies will feel a general malaise. The mother can typically tell that the baby's feeling a bit off, and they will feel quite sick sometimes. Some babies have difficulties feeding, and in more advanced cases, the babies will have a pale stool like a white or a gray, and a dark amber or brown urine. Currently, Henry has not started any therapy for his jaundice yet and is feeling quite off, and he is colicky at times. He is hemodynamically stable, however he has a temp of 38.3. He has slight yellowing of the whites of the eyes, but it has not moved to his head, face, or any of the rest of the body. His bilirubin level is 7 milligrams per deciliter, and his blood sample contained fragmented red blood cells. He is currently trying to be hydrated through breast milk, however is experiencing some difficulties feeding. He has dark amber urine, but normal stool color and consistency, however there's a reduced output. Jane is starting to get a little bit anxious about not being able to feed properly and reduced skin-on-skin contact.
In order to understand jaundice, you must understand the byproduct that causes jaundice, bilirubin. The production of bilirubin is an immune response maintained by macrophages to facilitate the breakdown of hemoglobin into its more easily excreted counterpart, heme. In the early stages of bilirubin production, it is a lipid-soluble molecule, meaning that cannot be adequately excreted. To counteract this, the body sends it to the liver for metabolism bound to albumin. Unconjugated bilirubin must be metabolized in the liver initially to break it down into a water-soluble counterpart. This way, it can pass through the glomerular filtration and be excreted as urine. As heme, the iron compartment of hemoglobin, catabolizes. In the human body, it creates bilirubin. Using an oxidation-reduction reaction, it not only creates and excretes excess waste products such as bilirubin, but also is the body's natural way to maintain adequate iron levels. It's this mechanism of homeostasis that regulates levels of bilirubin in the blood and prevents toxicity. When this mechanism stops working, bilirubin stays in its unconjugated form, and unable to be excreted by the kidneys, it accumulates in the bloodstream. Jaundice is the discoloration of the sclera and the skin caused by elevated serum bilirubin concentration, which is termed hyperbilirubemia. The yellowing telltale signs of jaundice is usually visible in the sclera when bilirubin is 2 to 3 milligrams per deciliter, and in the skin when bilirubin is 4 to 5 milligrams per deciliter, but will vary with skin tones. The term of unconjugated bilirubin that most commonly accumulates in neonatal infants is indirect bilirubemia, and almost half of all neonates show signs of this condition after birth. As previously mentioned, this is a very common condition amongst neonates. This is mostly due to the physiological developmental stage in which babies are born during, but there are many more simplistic ways in which the condition occurs. Physiologic jaundice occurs when a newborn baby is unable to excrete an adequate amount of unconjugated bilirubin, causing pathological toxicity and yellowing of the sclera. Neonatal, particularly preterm babies, have the highest risk of developing jaundice. This is due to the shorter lifespan of their red blood cells and the immaturity of their liver after birth. As previously mentioned, bilirubin is the waste product of red blood cells. Neonatal children have the red blood cell lifespan of 60 to 90 days, with an even shorter lifespan of 35 to 55 days in neonatals, meaning there is an increase in the byproduct bilirubin in neonatal circulation. In combination with an increase in bilirubin, the neonatal liver is immature post-birth. As this is a vital organ responsible for the conversion of unconjugated bilirubin into conjugated bilirubin, it is unable to maintain adequate metabolism of the bilirubin, increasing unconjugated bilirubin that is unable to be metabolized. It is the increase in hemoglobin byproduct in combination with the undeveloped liver that makes jaundice so common in preterm babies. But it is the behavior of the bilirubin that makes it life-threatening. This condition occurs due to the albumin-binding mechanisms allowing excess bilirubin to cross the blood-brain barrier, creating toxicity. Though Henry has been diagnosed with physiologic unconjugated jaundice before this diagnosis, it was vital to have other reasons for his jaundice ruled out. Mechanisms of jaundice in neonatal includes breastfeeding failure, breast milk jaundice, and hemolysis jaundice. Breastfeeding jaundice is caused by no fault of the mother by an inability to breastfeed the baby. The decrease in necessary fluid causes dehydration and a decrease in urine output. The decrease in urine output causes a buildup of bilirubin in the blood that is unable to be excreted. About 2% of breastfed babies get jaundice. This happens later in their first week of life. It peaks at about 2 weeks of age. It can last 3 to 12 weeks. It is not dangerous, but tests may need to be done before other dangerous problems can be ruled out. This issue may be caused by a substance in breast milk. The substance may increase how much bilirubin the baby's body can reabsorb. If your baby has RH disease, hemolysis disease of a newborn, due to having a different blood type from the mother's, he or she may get this type of jaundice.
When discussing jaundice in our pediatric patient Henry, the biggest potential complication of concern is any damage to the brain or brain function. Bilirubin, or the byproduct produced from the breakdown of red blood cells, is a normal compound that the body typically eliminates through the liver. When a patient has jaundice or an excess of bilirubin in the blood, and it is undiagnosed or untreated for a long period of time, it can lead to the buildup of bilirubin in the brain and cause a type of brain damage called bilirubin encephalopathy. Bilirubin encephalopathy has two main stages. The initial or acute stage is known as acute bilirubin encephalopathy and typically presents itself through certain phases of signs and symptoms that are separate from the typical sign of jaundice, which is a yellowish tint to the skin. In the early days of this complication, there are non-specific symptoms such as slight lethargy, poor feeding, poor muscle tone, slight spasms in the muscles of the neck, and a slightly high-pitched cry. Typically, after a week of this complication, other symptoms begin to take effect, such as a moderate stupor, which is essentially a state of near unconsciousness, irritability, fever, arching of the back, and a very high-pitched cry. Once acute bilirubin encephalopathy has gone untreated for this long, it enters its most severe phase of symptoms, which is the second stage of this complication. This severe stage is known as kernicterus. What makes this stage of bilirubin encephalopathy significant is that once the patient enters this stage of brain damage, the effects can be chronic and irreversible, and in some cases even lead to death. Symptoms can include a deep stupor or coma, high-pitched crying, pronounced muscle spasms in the neck, refusal of feeding altogether, hearing and visual dysfunctions, writhing caused by muscle contractions, pronounced lack of muscle tone, and while presenting in less than 50% of those affected, seizures. Long-lasting effects of kernicterus can present themselves up to a year after the acute phase of bilirubin encephalopathy through abnormal motor control, poor muscle tone, hearing difficulties, and visual impairments. While this all sounds very scary, incidents of acute bilirubin encephalopathy are significantly rarer in developed countries. However, they still occur at rates of 1.2 to 1.3 per 100,000 live births. Significant risk factors for bilirubin encephalopathy include any conditions or characteristics of the child that may delay diagnosis. In our patient Henry, that includes the colour of his skin. Patients with varying pigments in their skin can make it more difficult to diagnose jaundice, which can put them at risk for developing bilirubin encephalopathy, which is why rigorous observations of paediatric patients for signs of jaundice is essential for the prevention of serious complications, such as bilirubin encephalopathy. Other risk factors include premature birth, as immaturity of the brain cells can increase their likelihood of damage, or sepsis, which increases blood-brain permeability and allows for the buildup of harmful compounds in the brain, such as bilirubin. When treating a patient like Henry, it's important to establish goals of care that will reduce his risk of developing potentially life-altering complications as a result of his jaundice. The first goal will be for Henry's temperature to drop from his current 38.3 degrees to a temperature within 36.5 to 37.5 within the next day. The second goal will be for the yellow tint in Henry's eyes to reduce and return to white within 3 days. The third and final goal for Henry will be to increase his hydration to adequate levels and ensure his output is appropriate in relation to his intake. With these goals in mind, we can tailor our nursing interventions towards rectifying these issues and aim to avoid the complications mentioned previously.
Now that it's understood what goals are necessary for Henry's care, action can be taken. This is going to be broken down into 3 sections relevant to each of the goals that have previously been mentioned by Ethan. First, we're going to be taking a look at interventions relevant to Henry's temperature. Now, although Henry's most likely cause of fever is the body's attempt at metabolizing the excess of the bilirubin in his blood, it is still crucial that we make sure that there's no other underlying cause for him being febrile. Ways that we can do this is by assessing the environment and psychological factors. We also need to be observing for clinical signs of infection and or sepsis. It's important that hourly auxiliary temperature checks are taken and documented until we have at least 2 consecutive measurements under 37.5. To help manage his temperature, we can always reduce the temperature of his cot as well. Once Henry commences phototherapy, it's important that we continue to monitor his temperature, making sure that we don't have another spike. Once it is stabilized, we need to be recording this at least 4th hourly. It is important that we observe for signs of overheating, particularly by looking for skin rashes. Although this rash is only temporary, it is showing that the phototherapy lights are too hot and there is a potential to overheat the skin. Now we're going to discuss interventions relevant to goal 2. This is going to lead to phototherapy. So the commencement to administer phototherapy is made by the doctor, but once both the dose and the most appropriate method of delivery has been determined, it is important that the nurse continues to monitor Henry's weight, his hydration, and his bilirubin levels. And this needs to be performed during treatment as per local protocol of the individual hospital. Skin and eye care for Henry is also important. When it comes to Henry's skin, we want to be making sure that his skin is clean and dry. We want to also be proactive with the early use of barrier creams if Henry starts to experience any loose or green stools.
When it comes to eye care for Henry, we want him to be wearing the phototherapy mask, which is eye protection, without question if he's going to be using the overhead phototherapy. And if he's going to be doing phototherapy with the Billy blanket wrapped in the cot, it's up to the nurse's discretion whether or not she thinks that it's fit for him to be wearing the phototherapy mask. Now, what's also really important is support for Henry's parents. We want to be minimizing any separation anxiety and worries that we can as much as possible. We want to be encouraging the parents with stroking, cuddling, eye contact, talking to Henry during feeding times. And we also want to encourage Henry's mum and dad to interact with him in the nursery in between feedings if possible. We want to be giving his parents a very clear explanation of jaundice, the process of phototherapy, what to expect, what nursing care Henry will require while he's under these lights. And we want to also encourage Henry's mum to continue breastfeeding if she wishes to throughout this journey as well. Lastly, we want to be looking out for the side effects of phototherapy. So these can include the loose green bowel motions that we just previously mentioned, any dehydration and the skin rashes as well. Lastly, let's have a look at the interventions relevant to increasing Henry's hydration to adequate levels and ensuring that his output is appropriate for his age. So first of all infants that are admitted to the newborn care for the management of jaundice will be seen by a high-risk lactation specialist. So if this stage hasn't happened yet, the nurse needs to be aware of this and needs to follow up on this because this is crucial. This lactation specialist will assist the nurse and the mum in implementing and individualizing a feeding plan appropriate for mum and bub. So the nurse needs to just be aware of this plan, make sure mum is aware of the plan and following the plan because this can help prevent dehydration from occurring while bub is undergoing phototherapy. Education should also be provided to mum about expressing, especially if Henry is sleepy or he's unwell and not feeding as much. This was briefly discussed before. It has a role in maintaining and increasing mum's milk supply. Now, it's also important that the nurse is accurately documenting Henry's fluid intake and his output, also recording his stool losses. The nurse needs to be aware of any changes in his urine output. Is it reduced? Does he have any signs of dehydration? So looking for depressed fontanelles, dry or warm skin with poor tugor, sunken eyes. Now, this is all really important because there's a couple of factors that could potentially lead to hydration in Henry. It's not uncommon for infants to maybe sleep for longer periods in conjunction with phototherapy. So this is already increasing the risk of dehydration if the frequent feeding schedule is not maintained. Also, water losses can be lost through stools and evaporation. So it's really crucial that the nurse just stays on top of all of these different factors. So now that action has been taken, we must ensure that our actions and interventions had a positive impact. So this can be done through the process of evaluation. So if the mentioned actions were implemented, the following outcomes should be imaginable. So Henry's temperature is now stable and is in within normal limits relevant to his age. Henry's mum is able to verbalize an understanding of the cause, treatment, and possible outcomes of hyperbilirubinemia. Henry has completed an exchange of phototherapy transfusion without complications. Henry has displayed decreasing serum bilirubin levels. Henry has shown resolution of jaundice by the end of his first week of life. Henry has maintained a fluid balance within normal limits.
In summary, if all these nursing interventions are implemented immediately and effectively, Henry will have a full chance of recovery and mum and bub can go home from the hospital. Thanks for watching.